I'd like to hand over to Nick and very warm welcome, Tim, Professor Timothy Davis. And yeah, over to you, Nick. Thank you.
So I just want to say formal welcome both to Tim, who's speaking today, and to Wendy. They're both here on sabbatical from Western Australia. And Tim's going to talk today about the Fremantle Diabetes Study. So he starts where we usually stop. So we often stop at the point of incidence of disease, and Tim and Wendy start from that point, going on to complications. And it's great that you're spending time in the IMS. I'm sorry it's the fag end of the summer, and you know, people haven't been around quite as much, but you are staying here, I believe, until both of you until Christmas, November time. And the fact that they're in Europe at a time when the Rugby World Cup is on is entirely, but I have it on good authority that Tim will be disappearing to France pretty soon.
This weekend, yes.
In the vain hope that the Wallabies
I've
given up on that already. In the vain hope that they do well. Anyway, you have tickets for the final, I think.
I do, yes.
So we might see him barely sobered up in November time. But it's great that you're both here. Welcome.
Thanks, Nick. So I basically designed the title to reflect what Nick just said, that I spent the last 30 odd years working on this boutique cohort study, and I thought I'd share with you some thoughts about whether they have a role and how they can stack up against other epidemiological methods. Now, I'm just... How do I advance the...
There it is, yeah.
So I don't have any conflicts of interest. And I thought I'd just give you a bit of a background about me, so you know who I am. So I was a medical student at my local university in the 70s. I went to Oxford and did a DPhil. And after that, I trained in endocrinology in the UK here, and mostly in London. And then I did, when I was at senior registrar level, I did a right turn. I got offered a job in Oxford University's tropical medicine unit in Bangkok. And was it Boswell who said, if you tire of London, you tire of life? I was anti-Boswell. I'd had enough of London and I wanted to go home for a while, and Thailand was on the way. So I did a 3 or 4 year postdoc in a completely new area. And then I got offered my current job back in my old university in the port city of Fremantle, which you'll see in a minute. And I wanted to keep doing tropical medicine, but I also wanted to reactivate my diabetes interest. And you'll hear a bit about that in a minute. And so at this stage, I'd like to just acknowledge my mentor at Oxford, the late Robert Turner. He was actually Steve O'Reilly's mentor as well, and a lot of other very notable researchers around the UK, including Andrew Hattersley, who was not long after me in the unit. And he was the principal investigator of the UK PDS, and I was lucky enough to actually do some use some data from the UK PDS, and I'm an author on about half a dozen papers from that trial.
You might need to explain, not everyone in the room might know what the
United Kingdom Prospective Diabetes Study was probably the first decent randomised controlled trial ever conducted. It came in the aftermath of something called the UDGP, which is a complete mess of a study done in the United States. There was protocol violations, commercial leaks, all sorts of problems. And so Robert and his colleagues got together and designed, with Richard Peto, the Rolls-Royce in those days study, and it still has implications for what we do today, and I'll show you how in my talk. So I've been a bit schizophrenic. Even now, I'm still involved in malaria studies, and they are in Papua New Guinea. This is the Goroka show in the highlands. And we do mainly randomized clinical trials in PNG, and this is probably our sentinel paper, mainly in kids and pregnant women, because they're the ones that get malaria the most in these sorts of endemic areas. Now, just to give you a bit of background for where we are, so this is Australia. It's about the size of mainland USA, so it's not a small place. And we're in Perth, and we were watching the Women's World Cup recently. The commentator said, I'm here in Perth, the most isolated capital city in the world. And that's probably true. And the other thing to comment at this stage is that if you look to the east of the country, you'll see Sydney and Melbourne and Brisbane. And there is definitely a chip on the shoulder attitude for people like me that were born and grew up in Perth, because if you live in Sydney, the only thing that Western Australia is good for is generating iron ore and therefore keeping the Australian economy alive. And they don't rate Perth as having any intellectual excellence at all. So this is Perth. The Swan River snakes down the middle of it. There's a few things I would like to point out. It's a city of about now 2.5 million people, so it's not small. That's Fremantle Hospital where I work. So I can actually see the ocean from my office. And Wendy and I live just up here on one of these beaches, about 400 metres from the beach. It's quite a pleasant place to live, really. And I drive down the coast every day to work, sometimes seeing whales out there, sometimes seeing nuclear submarines. The other thing to point out is that Perth is about 13 kilometres upstream, and that's the city centre. It's, as I say, it's Perth's a very long. No one wants to live more than 20 kilometres from the beach, so it's probably the longest city in the world. It's probably 100 kilometres long, but Perth is inland from Fremantle. The other place I'd like to point out is this building here. Now that's the terminal at Fremantle Port, and after World War II, a lot of people from Southern Europe wanted to get out and start a new life. And so they got on these boats and they came to Australia. And in those days, boats didn't go very fast and they were not particularly nice places to be on. And so people, when they got to this terminal, often decided we're not going any further. We're not going on to Adelaide or Melbourne or Sydney. We're getting off here. So this whole area in Fremantle has, and still has, a very strong Southern European flavour. And in fact, the main strip in Fremantle is called the Cappuccino Strip because there are so many coffee shops run by second generation and third generation Italians. So when I was appointed to my current position in the early 1990s, there weren't any decent natural history studies of diabetes in well-characterised patients. There were studies like Framingham, and indeed in my own state, something called the Busselton Health Study, which is really a whole population observational study, of which in those days in Busselton, maybe 3 or 4% of the cohort had diabetes. At the same time, there was an emerging literature on how diabetes might be differentially affecting people based on race and ethnicity, and I was setting up shop in a very multi-ethnic part of Australia. And I looked on my desk when I sat down my first day on the job, and there was this consultancy that defined the primary and secondary catchment areas of Fremantle Hospital. And lo and behold, primary catchment area had about 120,000 people at that time. It's now about 160, 170,000. But that seemed to be a manageable, defined catchment area to do an observation study in type 2 diabetes. So I started the Fremantle Diabetes Study, and Wendy's one of my main collaborators, as well as being my wife. We started in 1993. We basically went out to find every single person with known diabetes we could in the catchment area of 120,000 people. At that stage, the prevalence was quite low. It's gone up since, but We found through clinic lists and allied health and pharmacies and advertising and word of mouth, about 2,200 patients, and we recruited 2/3 of them for ongoing observational epidemiological work. This is what we did, and it takes about 3 hours from the time the patient arrives to the time the patient leaves. Not all of this was done in FDS phase 1, because I'll tell you we've done phase 2 since, but most of the black stuff was done in FDS 1. And like all cohort studies where you try and collect information, it is quite taxing on the participants. And so we've tried to make it very streamlined. And this is in the day when there wasn't such a thing as online data entry and everyone had internet at home. And a lot of our patients having diabetes were elderly and not particularly computer literate either. So what we did was we did an extensive questionnaire, as you've seen, a physical examination, biochemical analysis, and we generated a non-judgmental report back to the GP about what the main findings were, on which they could act if they wanted. We made that available to each participant. We linked our data to the WA data linkage system, which probably was ahead of its time internationally as a data linkage system, because we could capture every single public and private hospitalisation in the state of Western Australia and death and cancer through that linkage. We also linked with the UK PDS for some of our studies, given my history, and there are a whole lot of sub-studies that we generated as well, and we banked as much biological specimens as we could for later analysis, and we're still dredging the freezers and doing analysis on 30-year-old sera. Whether that's valid or not, we can debate, but it's there for use. And these are the sorts of studies and publications arising from them that we looked at. I'm not going to go through them in any detail, but suffice to say that we're interested in basic epidemiology, we're interested in clinical management, we're interested in acute and chronic complications. We identified some unconventional complications. We were one of the first groups to identify that the lung is a target organ in diabetes, for example. And one of Wendy's jobs was to do some health economic analysis as well, in order to inform the health system as to how much we were spending on the disease. By the mid-2000s, we were following these people up every year with annual assessments for 5 years before the attrition was too great to sustain it beyond that. But there was strong accumulating evidence of rapidly changing epidemiology as well as management and outcome. You know, the UK PDS reported, DCCT reported, Statin Trial started to report, Hope started to publish papers. And so as a clinician, my practice was changing quite dramatically from the early 90s into the 2000s. And we identified a whole lot of our own deficiencies. We didn't recruit many Aboriginal patients, but there are too many living in the area, but we were not strong in that regard. We didn't concentrate enough on diet. We didn't have a good mental health assessment. Sleep apnea was a growing entity in the 90s, and we didn't capture that in FDS1. We're looking at some new techniques. We did skin fluorescence, which was coming in as a marker of glycosylation of proteins. We didn't have a camera back in FDS1. I used to do direct and indirect ophthalmoscopy myself, or we relied on specialist reports when we could get them from patients external to the study. We got interested in pulse wave velocity, and we tried to look at new and emerging risk markers like highly sensitive CRP and so on. So FDS2 was born, and we actually got decent funding from the national government to do this. Same strategy, 3-year recruitment, and then what we decided was, instead of doing annual reviews, things didn't change that quickly. We did biennial reviews for 6 years, so 3 of them, follow-ups, and sent the patients a postal questionnaire in the intervening years. This time, there were lots more patients identified with a higher prevalence in an expanded population in the same geographical area. We only identified about 35%, and that's because the government in the 1990s delivered funding to primary care to do annual cycle of health care plans. And GPs were now doing the sorts of screening that we were doing. And patients would often say to us, we don't want to come in because GP's just done the comprehensive annual review. Had my eyes checked, I've been with the podiatrist, I've had all my bloods done. I don't want to come into the study. The good news about Fremantle and WA is that once you come there and stay, you don't want to leave. So we've got a relatively stable population. And so we know where all of our patients, or almost all of them, are in both phases. And Wendy does a great job in tracking down all the deaths, so we can have accurate mortality data. And as I say, we've got data linkage, so we update that all the time. We've just had a new update, and we get a huge amount of information about outcomes. Now, you might say, 63% is a pretty good FDS1 recruitment rate for an epidemiological study, but 35% is not very good. But we did collect information on the people we identified but didn't recruit from available data sources. And as you can see, in both phases, we're looking at pretty representative samples in terms of age and gender or sex and type of diabetes and where they come from. Thing to notice here is that the Anglo-Celts have gone up in between phases, and that's because migration from Southern Europe has slowed. And now the 2 racial groups with the greatest representation, apart from UK doctors in Australia, are people from China and the subcontinent. And I understand that the subcontinent, Southern Asia, is now the biggest migrant group to Australia currently. The other thing is, people say, look, Fremantle's a funny place, it's got migrant population, blah, blah, blah. Is it representative of Australia? And the best we can do is that the Australian government have this index of relative socioeconomic advantage and disadvantage with an arbitrary mean of 1,000 and a standard deviation of 100. We applied it to our catchment area about the time FDS2 was about recruiting, and our average index was pretty close to the national average, and the distribution by postcode was also similar to what the national average was. And if you look on the right, there was quite a heterogeneous income distribution within the area that we're recruiting. And within that area, a whole lot of postcodes. We actually matched 4 to 1. We've got 4 people without diabetes from linked data to match with all our Fremantle diabetes participants. We matched on age, gender, and postcode, which is a very useful surrogate for socioeconomic status. So the limitations of the Fremantle Diabetes Study, I'll show you some of our findings in a minute, were that it is an urban environment, and especially in rural communities in a place as big as Australia, there can be very disparate differences between diabetes epidemiology and management in those settings. We didn't have a true control group that went through exactly the same set of assessments as we did with our patients, but as I've said, we've linked to the WA data linkage 4 to 1. We've got general population data from something called the Australian Institute of Health and Welfare, which looks at national trends. The Bustleton Health Study that I've mentioned already, we've got access to their rather small diabetic cohort. And we did our own diabetes study down in Bustleton as well, only about 200 participants, but again, useful supportive data. So just to review what cohort studies provide, they provide data where you can't do an RCT, usually for ethical reasons. You can't expose people deliberately to asbestos or cigarette smoke, for example. You can measure potential causes before the outcome has occurred. So if you're tracking people longitudinally, most cohort studies these days are prospective. Ours is actually a combination of retrospective and prospective because we've got data going back for at least 5 years before they were enrolled. We can examine multiple outcome variables and we can allow for the competing of death. We know when our patients die, as you've seen, and Wendy does very elegant competing risk analyses as part of our, as well as Cox proportional hazard modelling in a lot of our data analyses now. And you can calculate relative risk as long as the outcome of interest has enough power. The disadvantages are attrition, and that's obviously significant if the condition is uncommon. Because we can track deaths, attrition isn't such an issue, and because the data linking system captures hospitalizations, even if people haven't turned up to their scheduled in-person assessments, we can track them. Huge advantage of having the data linkage. We're unable, obviously, to adjust for all confounders. You need a randomized controlled trial to get rid of that effect. And there's obviously selection bias and health entrant effect in that probably people who are in nursing homes didn't want to come in face to face, so we probably missed especially the older and disabled participants in our catchment area. So I get this comment a lot from the wise men in the East, as we call them in Perth, that the FDS is a boutique study with limited generalisation, hence the title of this talk. And I'm going to give you an example of how we think it stacks up nationally and internationally. So first I'm going to go to the big one, which is cardiovascular disease. And as you know, even now people use Framingham, even though it's a 50s, 60s, largely Italian New England population. And with a simple tick box, whether you have diabetes, no matter what type, that's what the National Heart Foundation Australia still recommends. And then you've got the diabetes-specific UK-PDS risk engine, which is endorsed still in this country, I believe, for calculating cardiovascular risk if you've got type 2 diabetes. Now, the first thing we did in our cohort to see if they actually work, this is FDS1, and you'll notice that the number of participants is about half of what we recruited, but the point here is that they're primary prevention calculators, and lots of people have complications already. So we eliminated anyone who'd had an event, and we looked at the calculators, and you'll see that in the case of Framingham, there was an underestimation of the events that we saw. And when he ran the conventional discrimination and calibration analyses and found they weren't very good, he looked at the UK PDS, it grossly overestimated the number of events. Stroke wasn't so bad in the UK PDS. And so what we did in response to this was we generated our own risk calculator, the FDS calculator. It's online, and we validated it against an external population, the Busselton cohort, which is 200 kilometres south of Perth and quite an independent population, similar ethnic mix, mostly Anglo-Celt. And as you can see, the actual events versus predicted in the FDS and Busselton, even though it was a smaller cohort, stacked up reasonably well. Now, you might say, well, that's all very well for Fremantle. How does it stack up against all the other calculators? Well, this was published in June this year. This is an electronic health record US study of nearly 50,000 records with type 2 diabetes, where they looked at 16 cardiovascular risk models, including FDS1. And interestingly, we are equal best for stroke, and we are pretty good for all the others. And you'll pick up that they did use most of the ones that we're familiar with in clinical practice. So even internationally, our data in terms of cardiovascular events stacks up reasonably well. These three statistics aren't ideal, but they're as good as anything else that's around at the moment. We've gone one step further, so our latest version, which is not yet online, people are getting interested in heart failure as an additional outcome. So in trials, you'll be familiar with MACE, major adverse cardiovascular events, which is usually fatal and non-fatal MI, fatal and non-fatal stroke, and cardiovascular death, with or without revascularization and unstable angina. But people are now finding that heart failure should be added in. So we have now updated our risk engine. And as I say, it needs probably to be further validated and then put online for people to use. Another example in cardiovascular disease is AAA, which is abdominal aortic aneurysm. So this is looking down front of the abdomen. This is an angiogram showing this bulging structure here near the renal arteries before the bifurcation of the aorta to the iliac arteries or the femoral arteries. And this is an aneurysm. It's a ballooning out of blood vessels. And what happens is it can rupture. So this is blood seeping through the calcified vessel wall. And that can be a surgical emergency and associated with you ending up with the circulating blood volume in your abdomen and death. So it's a pretty important complication to identify. And if you do identify it, you can stick in a nice sleeve and stent the vessel and stop the rupture. Now, diabetes, as we all know, hopefully is associated with vascular disease. And we thought, let's have a look at AAAs and see if they are increased. So this was one of the first papers we published back 23 years ago, where we got one of the vascular surgery fellows to bring his ultrasound machine into our assessments and do aortic diameter. And what he found was that compared to a population-based study of general population Perth men, the prevalence is about half. Highly statistically significantly reduced. Now, it turns out that this is the only vascular complication where it's good news to have diabetes. And now there's a growth industry. So here is a paper from a couple of years ago where lots of other groups have confirmed what we found. And it probably relates to glycosylation of arterial wall proteins, which stiffens the aorta and stops the aneurysmal pathology. So that's an example of how what we were expecting didn't come about, but we weren't wrong. So what about hepatobiliary disease? Now, I go to conferences where my gastroenterological colleagues say, we're going to be swamped with all this nasty fatty liver disease and non-alcoholic steatohepatitis, which will generate fibrosis, cirrhosis, hepatocellular carcinoma, and a substantial amount of population will be affected. Is this true? Well, the answer is partly, and we've got data on this. And so we did a comparison of FDS2 versus FDS1 and did find that coding for non-alcoholic fatty liver disease and steatohepatitis went up between the two phases in association with greater obesity in the second group, but they're not that common. And for example, hepatobiliary disease-related deaths, only 10% of them were due to fatty liver disease, and that was less than 4% of the total mortality, which is not as much as my gastroenterological colleagues will lead you to believe. Now, it's interesting that RAS blockers, renin-angiotensin system blockers, are antifibrotic. There's evidence that some of the lipid-lowering drugs we use are protective against fat accumulation in the liver, and now everyone's on GLP-1 agonists and SGLT2 inhibitors, which will thin out the fat in your liver as well. So I'm not convinced that we need to put a lot of public investment into liver transplant units and so on, because I actually don't believe we're anywhere near a tsunami. Maybe it's a slight tidal surge, but not a tsunami. And lastly, another example of how our data has stacked up is Helicobacter pylori, and I put in a plug. This is Barry Marshall. He's actually a Nobel laureate who works in my department in Perth. He discovered Helicobacter, revolutionised treatment of peptic ulcer disease. We got interested in this because although since FDS1 recommendations for regular aspirin have changed, so now it's more conservative. We use it for secondary prevention rather than primary prevention. But back in the day, if you had diabetes, you probably were going to end up on low-dose aspirin. And we wondered whether if you had Helicobacter and you added in aspirin, you were doing the patient a disservice and increasing the risk of gastric ulceration and perhaps serious complications and even death. So what we did was, and this was in collaboration with one of our Swiss postdoc trainees who used to come and stay a couple of years with us, we looked at the relationship between antiplatelet therapy, Helicobacter serological positivity, and complicated peptic ulcer disease. And we found that indeed diabetes is a big risk factor for peptic ulcer disease. This is in the days after Barry Marshall's discovery and how we should be now treating Helicobacter with antibiotics and PPIs. There was 7 times increased rate compared to the general population of complicated or peptic ulcer admissions. But this was not related to whether the patient was on aspirin or they had evidence of Helicobacter infection or their interaction. So this was clinically reassuring that I didn't have to do Helicobacter serology on all my patients if I was going to stick them on aspirin to try and prevent them from having an ulcer. Now, as some of you will know, there was a vogue for putting the finger on microorganisms as making cardiovascular events worse, getting into plaques, infecting plaques in vesicular walls, making them unstable. It's less of a vogue now, but at the time there was this story that maybe Helicobacter was one of them and increased cardiovascular events. So we decided to look at this and we targeted something called cytotoxin-associated gene A antibodies. Cytotoxin-associated gene A is the nasty variant of Helicobacter that gives you the worst upper GI problems. And to cut a long story short, we actually found that there was no predictive effect on cardiovascular complications or death, with one exception. So we did a cross-sectional study and we looked at the CAG-A seropositivity, no association, but we did find that despite our hypothesis that in fact if you had these antibodies, you were protected against cardiovascular death after adjustment. Now, our policy in the FDS is if we find something, we report it. We don't bury it, we don't try and explain it away, we put it out there. And lo and behold, about a year later in the same journal, quite a reputable European journal, these guys came along and did a population-based, not diabetes this time, but German population-based large study, and they found exactly the same thing. And in their discussion, they say, we found this funny Australian study that did find what we found, and so we're reassured. So again, this is another example of how in cohort studies, because you haven't got a definite hypothesis and you may be looking for things based on flawed background knowledge, if you find something, report it. because even though it might be counterintuitive, it might be right. So to answer the question I posed at the beginning of the talk, I do definitely think, and not because I've got so much invested in the study, but they do have a role in diabetes epidemiology, and the study that I've run has educated me significantly in my clinical practice over the last 30 years. They've got to be well designed, representative sample, detailed data collection, long duration follow-up so you accumulate enough events to do meaningful analyses. They can reveal expected findings. So we did expect a surge in NAFLD, not to tsunami proportions, and unexpected. So the fact that we were diabetes protective against AAA did come out of left field for us. But time and time again, we publish stuff in the literature that is either confirmed by previous work or confirmed prospectively by others, and that validates us all the time. I don't think we've ever had a finding that we've really thought this is just crazy, and it results from the fact we've got a small cohort that's from a funny part of the world. All of our findings have really been quite consistent. So just to finish, it's a huge burden on the patients, but funnily enough, they actually quite like coming back. They like the interaction with our nurses. They do like the fact we give them a report that prods their GP to do something. So they say, here's my report from the study, you know, my cholesterol's high, what are you going to do? We've had good financial support. As I say, my wife Wendy's been a co-PI, and David Bruce is a geriatrician, now retired, was there from the outset, and we've had an awful lot of collaborators over the years. And this is where next plug comes in. So
Yes.
I was fortunate to be at the Emirates Stadium a couple of weekends ago to see Arsenal beat Manchester United 3-1, and sitting next to Chris Chatterjee, who Nick tells me actually for a change stayed to the end of the game and was very happy that he did. In Australia, we're often sort of compared to the Little League, and I go to national meetings. I have to keep fighting for the Fremantle study as being quite a useful piece of work on a national scale. And I'd like to think that we're up there with Framingham. Interestingly, not much bigger than us in terms of sample size. So I'd like to think that this is the view from my office, but it is actually the view west from Fremantle towards South Africa. So thanks.